While you're doing that, let me just say this was really um, a really wonderful opportunity and success story for community involvement. The ATI issue. I mean, I know that I worked within the MDC cab. That's the overarching cab for the Martin Delaney Collaboratories to get community. No, I don't know if I want to say consensus, but pretty much agreement on what these guidelines should look like. Richard did Herculean work looking at all of these studies and also did a large survey from people trying to really take the pulse of what the community thought about this stuff. I mean, we were fabulous at that Raygon meeting as far as pushing our stuff through. The only thing that we didn't get was the nadir that we wanted, and I think there's some question about what that really means. But we really did, we really were very successful in all of this. One of the biggest problems was what do we do about participants, the partners of participants getting infected, while they were on these ATIs. So I'm going to talk about that now. And Richard, I see you have my slides up, so I think we can go to the next one. So I'm going to talk a little bit about some AMFAR UCSF studies about the ATIs being the gold standard, the risk for partner transmission, recent cases of transmission, and what we came up with as far as PrEP usage and access to prevent transmission, challenges, implementation recommendations, and limitations of our paper and future studies. Okay, next, please. So, what is going on? What will be going on here is at the AMFAR Cure Institute, which is located within UCSF. There is about to begin a huge study. It's not huge as far as number of people, but there's so much going on in this that the nickname for this study is Jaws. Now we got a social science study nested within this, so that those things are important. But before the study even happened, we worked with the UCSF team, and you can go to the next one, please, to get these PrEP recommendations implemented within this study. Knowing that that was such a huge unmet area, we really pushed to get these recommendations and these procedures included before we even started. There is actually we've got the paper accepted, approved already. So there's the citation, and I need to stress that this paper and these recommendations are practical starting points to address HIV transmission. And might these recommendations hopefully will be utilized in upcoming clinical trials, and that they may be applicable to some other centers. And mostly, I think what we're talking about, again, this all comes from UCSF, which is, they have a lot of resources in San Francisco and a lot of access to PrEP. So that might not always be the case, especially in rural areas. But we hope that these recommendations will apply to other university-based centers that have PrEP access, readily available. Okay. So I'm sorry, I haven't been on the whole call. I've been really sick the last couple of days, so hopefully I won't repeat anything, but that's already been said. But we use these ATIs at this point. They're the gold standard because we don't have any way to standardize a measure for the latent virus that everybody agrees on, that's validated or universally acceptable. And as Richard was alluding to, we also have these docs that are saying, okay, well, we really need to see how high the immune system needs to go to make sure we're not losing ourselves here, and hopefully, these boosts will get the immune system working again. So I think we're going to be stuck with these ATIs even once we have decent measures for the latent virus because people are going to want to keep experimenting with boosting the immune system and letting it rip. And I agree with Richard that I think over 100,000 is too much. But anyway, so there's obviously risk of HIV transmission during ATIs, and undetectable status lost. Obviously, there's public health adverse event implicate possible adverse events and implications, risk to partners, and of course negative impact on future ATI trials. And what we're having here is directly related to the duration of ATIs and peak levels of viremia during rebound. So, okay, next. So the recent cases we've heard about the case in France with a male to female transmission in 2014, and in Spain a male to male transmission case. So we felt like there was a really urgent need to try to mitigate study risk, or transmission risk during studies. Unfortunately, PrEP was not available in France and Spain during these studies, but it is available now. So hopefully that will help. But again, I mean, a lot of this stuff is going to be conditioned on PrEP being available and widely accessible. So these are the recommendations that we've come up with from the JAWS protocol. And there's always in these really early sorts of studies and risky studies standard exclusions for pregnancy, contraception plans to limit pregnancy. And, we really felt like exclusion based on other sexual criteria or other sexual behaviors might not be appropriate because, people's behavior changes. We've all experienced years of excluding patients who use drugs that we think that many of us think were unreasonable. So we thought that when PrEP is available, there might be some more appropriate and reasonable ways to look at this. But we did recognize that, in some participants there might be a need to restart ART if there are repeated instances of sexually transmitted infections. If people were not able to be sure that they weren't um, having unprotected sex during these ATIs, they may not be a good candidate for these studies, and that their ART should be repeated. So, that's a tough call, but certainly we agreed that it had to be more than once. And anyway, so let's jump to the challenges. I mean, it's difficult to disclose that your HIV status. Um, and the disclosure transmission risk during ATIs is probably even more complicated because there's uh, not often in this arena counseling that's consistent. I mean, if anybody's ever been in a study, a lot of this stuff depends on your study nurse. How well you get a consent form that you understand, and how much information you get that's not just generic. And oftentimes there's no consistency or follow up, during the study. And of course, there's always the problems of anonymous partners. So we thought we'd try to address the things that we could address, including consistency throughout the study, help with disclosing status, and we'll see a little bit more. And next slide, please, as we go on here. So the challenges again, most people in the community think we should put PrEP in the water, and that would be great, especially in these study situations. But the problem is that the partners of study participants are outside the scope of research per se. There are medical, regulatory, legal, financial issues that we're in the United States. Being a lawyer, how I know how that goes. It's really very difficult to try and get some of this stuff done under the circumstances. There's no direct uniform risk information to partners usually, no direct mitigation efforts. So again, the counseling is usually generic and lacks in the engagement that we're going to recommend. Next, please. So what we have designed and what this paper entails is a collaborative, multidisciplinary approach involving consultation among the biomedical study team, our community advisory board, which included men and women with and affected by HIV, some of whom were also study participants, and social behavioral scientists and bioethicists. Um, and obviously PrEP is our intervention and based on CDC HIV prevention recommendations. So that team, I think, is really important, and it was essential to have the community and the community that is so was diverse and involved and familiar with all of these issues. Okay. So our recommendations were direct study team engagement. Now, what does that mean? So across the study, across the study. So we try to determine a standard of I'm sorry, I'm really not feeling well. Prevention, testing and disclosure in discordant couples, collaboration of study team participants, creation of a study-specific risk reduction package. So what we did was we did forms to first of all help people disclose their status. And also we created rules that were actually part of the study team that outlined how the team needed to deal with people on the study. And in other words, okay, let's go to the next one because I think I'm going to get into some of this. So what we developed was a hands-on study team engagement throughout, where counseling and assistance was also available throughout, where there was consistent messaging that happened throughout the study. We created a disclosure script to help facilitate disclosure, to help people try and describe not only that they were HIV positive, but scientific facts about ATI transmission. So we have written PrEP facts and access info for partners, and again repeated transmission counseling throughout the study. What we were looking for is something that was really consistent for every participant in the beginning, middle, and end throughout the whole study. So participants were encouraged to engage their partners, invite them to regular study visits, to participate at least 4 weeks prior to the ATI, again, providing written PrEP facts and access information to partners. So study development information sheets, including specifically developed information for women. And when we say written PrEP facts and access information to partners, we are not recommending that we just say, okay, here's where a PrEP clinic is, and then just leave people to their own devices. Next slide, please. What we recommended was aggressive PrEP navigation assistance. So just for instance, at UCSF, I mean, some of these clinics are right in the same building or one floor away from where the study was happening. So instead of just saying, okay, here's information, I mean, we were talking about warm handoffs so that somebody from the study can bring people to the actual clinic at UCSF where they could get PrEP, and to make this as easy as possible. So included in the aggressive PrEP navigation are access to the study physician to discuss PrEP issues with the participant and their partners. Again, repeated initial and repeated transmission counseling throughout, direct referrals, and warm handoffs to PrEP sites at least 4 weeks before ATIs. Again, study site teams accompany partners to UCSF sites and directly connect them with any off-site prep clinics, and that means calling the prep clinic, sitting there while the person gets either enrolled or um, um, finds out the information they need to get enrolled into one of these clinics, and not just leaving people again to their own devices. Okay, next, please. Okay. So, known possible exposure study. Oh, yeah. Once there is, they're talking about PrEP here now. I'm sorry. Once there was a known possible HIV exposure, the study team also promptly facilitate will also promptly facilitate PEP via established pathways already at UCSF. So we tried to consider PEP and PrEP sort of recommendations here. Next. So, again, our limitations, our study is based on San Francisco, where there's a widespread understanding of HIV transmission risks, where there's universal testing and access, and PrEP prevention, especially for men in San Francisco. There's also strong stakeholder support across the board and the political will to address these issues in San Francisco. Now, this reminds me of New York City, but maybe places like Boston, but not a lot of other places that this is so universally accepted. Although, both the CDC through their PrEP programs and initiatives, and the ending the HIV epidemic is also pushing this throughout the country. So it's going to be a lot easier for people to access PrEP in a lot of places. Um, Next, please. Of course, that's always, I mean, there are always certain communities that are always left behind. So, and that takes us to our limitations on the recommendations we've made. Obviously there are so many unknown PrEP use considerations in women. There are so many people that don't know their HIV status, that are unaware of the benefits of PrEP, multiple or anonymous partners, and the unwillingness of participants to disclose their HIV status and their unwillingness to involve partners. So if they're not willing to be involved in such a program to prevent transmission, then, I mean, we're kind of stuck. Next, please. And again, no access to local research or PrEP access centers is always a problem, and this is especially true for communities of color, especially in the southern U.S. and other rural settings. And of course, there are resource limited settings where cure related research is likely to be conducted. But then there are places like Thailand where this stuff happens for PrEP and PrEP automatically. I mean, they do kind of what we're talking about here, and these clinics are very close to each other, and things are not, they don't have the siloed history of prevention and treatment that we've had in the United States. Next, please. So, future directions, universal HIV testing, we know is enough. It's so important. PrEP education and access are essential to all communities everywhere. We need to be sure to address the risks faced by women and people of color regarding even knowing about PrEP, referrals, use, and access are of particular importance. More behavioral research needed to understand um, these values, motives, and prevention practices in women, especially, and more research is also needed to identify the experience and preferences of participants' partners. I mean, we're just starting to do this for participants, let alone the people that they have sex with. So, and finally, I think we this can't be understated that researchers must collaborate with their local communities to create plans that are consistent with their local needs, including gender and sex dynamics, stigma, and intimate partner violence. So you really have to know your community and what your community is needs and is willing to be involved with. Next, please. Thank you. Here's the study team. Really, I tell you, I've never dealt with a university that said yes to everything that I asked for. You know, it was really wonderful. And dealing with Michael and Steve, John, Corinne was wonderful, and our community team. I also wanted to thank Richard and Michael for putting this meeting together. And oh my God, who would have thought that they would have had this? Talk about a Herculean task to get this together virtually after all the craziness that happened with Croy. And you know, I mean, how indebted are we to these the ATI participants that are willing to go through this sorts of research? And we always are grateful to people who are willing to come to our workshops, either virtually or in person. And I thank you all. That's it for me.
Thank you for that, Lynda. We had one question from Grace. It says, crazy thought, what would it mean if a trial designs an ATI study in a way that both the ATI study participant and their partner are enrolled and not just engaged? What would be the pros and cons of that sort of study design? I know you spoke briefly, just summatively. What would your sort of initial thoughts be?
Well, you know, the problem, I think I hope maybe I didn't explain it well enough, but that, you know, the participants are enrolled, but their partners are not enrolled. Okay? So, I mean, and the way we do it now, they're not in, you know, the participants would not be enrolled, and most of the doctors object to, I mean, they were crazy at the Reagan meeting, some of them, about having any responsibility towards the partners. So, you know, we didn't believe in that, but there are all sorts of legal and the financial and problematic issues. I mean, you know, we live in the United States where we don't even, you know, study participants, if things were to go wrong and they suffered you know, toxicity or adverse events, their future care is not covered. So, I mean, how do we include participants in this mix? Now, I'm not saying that it shouldn't happen or that maybe it won't happen in the future, but um, I don't know. Maybe I'm being too much of a lawyer here, but I see so many impediments to including um, partners, not the least of which are the researchers who feel like these trials are hard enough, complicated enough already, and adding that extra participant question is just something that many of them are not willing to take on.
Thank you for that. Jeff Taylor, you raised your hand.
Yeah,
Really
thanks,
quickly,
Danielle
Jeff.
and Linda. You know, just another thought on that last point. I mean, Linda's right. We probably couldn't make that happen in the U.S., but I would love to see it happen somewhere else and demonstrate that it can work. So there would be a precedent for us to build on here because that is a really important issue. And it's not a crazy
Yeah.
thought. It's actually a really good idea.
No, I don't think it's crazy either. And as I was talking, Jeff, I was thinking the same thing. Wow, I bet they could do this in Thailand. You
Mm.
know,
Yeah,
so
yeah.
yeah,
So
so I
my
think
main
that's a really
comment
important
was,
point.
yeah, sorry. Yeah, my comment was on the, you know, how we deal with the participants during the interruption. And I've been talking with Christian Brander in Barcelona, and he's been doing a vaccine study there. And it's really fascinating. And of course, they have the warm handoff we were talking about. They have an organization that provides prep throughout the city called BCN Checkpoint. Many of you may know Michael Mielbrook and Baran Pujol, who often come to Croy. And so they have that set in place, and it's a warm handoff. They send them right there, and they can cover everybody. But another thing they had, which is really fascinating, and I think we should consider in future trials, is they have a psychologist on staff to talk to patients who have any anxiety about being off their meds or about having a detectable viral load while they're off their meds, or if they should be forced to go back on, you know, if the treatment doesn't work and have to go back on their meds to help them deal with the letdown from that, as we heard about from the Boston patient, Gary Steinkohl. So I thought that was a really fascinating thing and something we should consider in the future trials.
Just think how helpful that would be.
Right?
Awesome. Thank you so much, Lynda, for your participation on today's trial, and definitely Jeff, for your points. I see a comment here from Rico. Says, and coincidentally, immune compromised people are more likely to be asymptomatic if they do contract things. So them being potentially infected for longer periods without any symptoms can actually increase their risk of death. Dyads or couples and studies involving ATIs seems like a very novel approach that would be perhaps be possible through smaller demonstration projects. Thank you for that comment, Rico. And then if there are no other questions, we can move on to the Beat HIV folks.